past 6 years at UVA, we've added a cardiac surgery nurse navigator. This role was a cornerstone in the care for our cardiac surgery patient population. As the first navigator that we had, I had over 20 years of CV surgery experience, plus a background in discharge planning and case management, which really helped with what we were trying to, our goal with this population and preventing readmissions. What the navigator did was keep the focus patient-centered. Everything was collaborative with the multidisciplinary team to make sure the patients were getting what they needed. It provided education and support to the patients and families surrounding that peri-op period. We helped to eliminate or at least identify barriers to care, and we maintained open communication with our patients throughout the process. One of the other things we did was we created a designated space for the navigator to do patient education with the patient that was away from the clinic, that the patient had time to sit down and sort of decompress and think about questions that they wanted to ask. And one of the things that stick out in my mind with this is we've done some time and motion studies prior to creating this quiet space. And it was an average of about 20 minutes or so that the nurses were spending doing education. We created the safe space. About 45 minutes to an hour was average. So a lot more questions asked and answered. Patients felt way more secure about going for surgery and having their questions asked. And plus they had that person that they could call if they needed anything. We then standardized all of our patient education into one binder, so the patients didn't have to be looking for whatever they needed. And that binder includes pre-op, post-op, and what to expect down the road for them. We gave them bags that contain the binder, an incentive spirometer, the Gatorade when we started ERAS, a toothbrush and toothpaste to remind them to brush their teeth, and also their sternal support device. All this was in their bag. They got pre-op so they could take it out, play with it, figure out how to use it, ask questions before surgery. We did initiate cardiac surgery ERAS protocols, and that helped a lot with readmissions and length of stay. It's a great program. We continue to do it. So it really impacted our patient population. The other thing we did in CV surgery at UVA is we hired a physical therapist for our clinic. We wanted to know what these people, their frailty level, how they were moving, their cognitive function prior to surgery. And she also does like the sit to stand testing, sternal precaution education, and depending on her assessment of the patient, if the patient is deemed frail, she may go to the attending and say, hey, any way we can put this surgery off for a bit, just to give them a little bit of time to, practice getting up and down without using their arms and increase their stability and increase their mobility and their functioning. So that is a tremendous asset that we have. We also created a pre-op social database to identify and help mitigate potential post-op issues. So on this database, we ask all kinds of things. Who do you live with? And not only who you live with, but who's going to help take care of you? Because sometimes that's not always the same person. And how are you going to get home? How do you get your medications? Do you have a support system? Do you have money to get what you need? We take those. In the beginning, we would take those questions and answers up to directly to our case management inpatient team so that they would know if a patient coming in was having issues that we knew about prior to surgery and what we had done about those. We also let our inpatient team know if we have somebody in clinic that we think is probably going to need rehab or need subacute rehab after surgery, so that decreases length of stay. It also helps decrease readmissions because we're thinking on the front end about what this patient's going to need. We did community outreach with our local skilled facilities and rehabs, and we provide what we call a circle back, whereas our navigators actually call the facility just to see how the patient's doing within 24 to 48 hours, make sure they have everything they need. If they don't have their sternal support, we try to get that to them. If they don't have, clarification on orders, we do that in the moment, fixing of those issues. We've now progressed to having video phone calls with our local high volume facilities where, creating that relationship where they have a contact at UVA if something's going on with that patient. And what they'll do is they'll call the navigator and say, this patient's having some issues with their sternum. Can you take a look at them? We can either have our APP team on the video look at it, or we can have them come back to clinic versus going to the ER where they're more likely to be admitted. So that's helped prevent a couple of readmissions just by having that in place. One of the big things I wanted to talk about today was we developed a readmission questionnaire. A piece of the puzzle that we were missing from readmissions is, what is the patient's perspective on why they're readmitted? I don't know that we had ever asked the patient or really listened to what they were saying. So we developed a tool to capture that in real time. So the navigators go up and actually interview the patient when they're readmitted. We also interview the team, the doctor, the attending physician, the fellow, the discharging LIP, the case management team. Were there any opportunities for improvement from their perspective that we could have done differently to help prevent this readmission on this patient? And one of the biggest lessons we learned is we had a young mother of 2 who had elective mechanical MBR done. The case management had talked to the patient. The patient said, yes, my sister's going to help me out when I go home. I don't need anything. And I'll be okay. And so we discharged her with no needs, no home health or anything like that. She was readmitted within 3 days with bilateral lower extremity clots. And these were due to not taking Coumadin that she was prescribed. Unfortunately, or fortunately, you would say, she actually filled her narcotic script, but didn't get everything else. And so, of course, the initial label was, oh, she just wanted the narcotics and didn't worry about the rest of it. When we went up and talked to this lady, it was very interesting because, as we all know, people that go on bypass, sometimes their cognitive functioning's not super duper right afterwards. So, in talking to her, her sister picked her up and was taking her home. We had sent her prescriptions to her local pharmacy to be filled, but by the time she got there, her pharmacy was closed. So she had the narcotic script in hand, because this was back before we could e-prescribe those. And so she got that filled. Well, the sister dropped her off, and then the sister drove 2 hours to her house. So the next day, when she could have picked up all of her meds, she didn't have transportation and she couldn't drive. One of her sons was 16, but he had some learning disabilities and stuff, so he did not drive. So there she was at home with these 2 young children and no medications. So what did we learn from that? We put a whole panel of folks together at UVA and included our pharmacists on that, and they really stepped up to the plate. And we decided that anybody who was new to Coumadin, our pharmacists would actually do their education before they left, at least talk to the patients, reinforce why it's important to continue the medications and follow-up plans. We also made sure that in the discharge summary, we have a plan and not, call your doctor or your doctor will call you, more of your appointment is this day. To be more specific when we talk to patients about who is going to help them out when they go home and make sure they're not getting left behind. UVA also had a program called Meds to Beds that they were piloting on another floor, where the pharmacy would actually deliver any discharge medications to the patient prior to discharge. So we rolled that out on the cardiac surgery floor so that when those patients leaving with Coumadin got their education, they actually had their medication in hand when they left. And I think above all, this one case, which thankfully was pretty early on in doing this readmission questionnaire, just validated the need for us to listen to what patients are telling us and maybe to probe a little bit deeper into the questions of social determinants of health, of what could be barriers for them. And again, I just want to thank you for allowing me to speak on our readmissions today. Thank you.